Briefly want to talk about equipment, then simple coiling, vessel takedown, dual microcatheter technique, balloon assisted, and then stent assisted coiling. In terms of the equipment, most of you are familiar with femoral access. We obviously want to be below the inguinal ligament. We typically shoot an X-ray as well as ultrasound, and we've kind of transitioned to using ultrasound for access. Other options are axillary or brachial, radial access for vertebral pathologies or posterior circulation pathology, carotid cut down or direct stick. So for people with very tortuous anatomy for pipeline, sometimes we've done that where you expose the carotid directly, or using a collateral circulation. I think I saw Aaron's got a picture of one of those that he'll talk about. There's lots of different arches. You'll be tested on them at the end of the talk. Just kidding. But you need to be aware of some of them. The type 1, type 2, type 3 arch, that's important to know. The type 3 arches are far more challenging. You need specialized equipment like Simmons catheters, etc., to access the innominate artery in particular. And as we get older, as patients get up in their 70s, 80s, as we're doing a lot of stroke interventions, you get a lot of these type 3 arches as patients become more unwound. And there's just a picture of a bovine arch with the left common coming off the brachiocephalic trunk. Sometimes they can have a common origin, as you see here. Other times they can be directly off the brachiocephalic trunk. Last week we had a difficult aortic arch. I'd never seen this before. I don't know if the visiting faculty had seen this. This is a duplicated aortic arch. Dr. Kalani or Dr. Dumont, have you ever seen that? So yeah, this is super rare. Of course, Shane had seen it, so that was that was good. We could talk about the different variations that he's seen. But if you look at that sort of donut here, the esophagus and the trachea actually go through that. So sometimes these patients can present with difficulty swallowing. It's kind of crazy, but yeah, it certainly made it a challenging angiogram. And then this is what I term a ridiculous arch. So this is a patient that has undergone previous surgery, and our goal was to try and catheterize the right common carotid artery, or right internal carotid artery. And as you can see from the reconstructions with the PA view, that's impossible. Different access catheters, the sort of tower of power, the coaxial system, so quadraxial or triaxial systems, so more and more catheters. We typically use a braided sheath or an arrow sheath that's pretty strong as our groin sheath, and then we get sequentially smaller and smaller, and depending on what you have to do, there's different catheters, and you'll see them next door. You can have straight microcatheters, steam shape them, so you can shape them into whatever shape you want, and pre-shape, which is what I tend to use because it's out of the box. We used to steam a lot more than we probably do now. I'm a particular fan of the candy cane pre-shaped catheter, which is a sort of a hook that can be very useful for getting into difficult PCAs. Micro wires is a whole different range, depending on what your goals are. You want different navigation, talkability, characteristics, shapeability, and size. Collateral access, so transcirculation. Sometimes you might want to go from the PCOM and put in a P1 stent. That can be helpful for a basilar type aneurysm, sort of a T-stent configuration, or contralateral vertebral artery we found useful for getting into a sharp turn for the pica. Sometimes it's easier coming across from the other vert straight into the pica. It's like a straight shot, and I'll show a case of that shortly. So this was a case last week with a extremely challenging arch to navigate for a posterior circulation case. So we went with radial access. So we have a radial cocktail that we use. I love this caption: "When he pours, he rains." You can only get that in the 80s. So we use a radial cocktail with verapamil, nitroglycerin, and heparin once you put the radial sheath in. So you can do an Allen's test pre-op. So we had a 7 French sheath, short sheath going in the radial artery, used a Sophia Plus at headway 17. And then you can confirm you've got good collateral flow down the ulnar into the hand. And then this is the pathology that we're dealing with. This is a mid-pica aneurysm, and obviously coming up through the left vert would have been challenging given the anatomy of the arch. And so we treated this with an Elvis stent. We have a series of these that's been submitted for publication where we haven't had to put in coils. And so far we've had 100% occlusion just with the Elvis stent on these mid-pica aneurysms. Contralateral vertebral artery access, so again coming up from the contralateral vert, going into the pica from one side, coiling from the ipsilateral side. This is a patient with methamphetamine use, subarachnoid hemorrhage, Fisher grade 3, put in an EVD. Patient had 5 aneurysms, 2 in the left MCA, 1 on the right MCA, basilar bifurcation in the left pica. And this is what we're dealing with here. So there was a ruptured MCA aneurysm, a second MCA aneurysm, and a 3 millimeter right anterior temporal, as well as a pica and a basilar aneurysm. So we clipped the anterior circulation aneurysms and then went ahead and treated the posterior circulation aneurysms with coiling. We stent coiled the basilar aneurysm with an Elvis stent and coils, and then just what I wanted to talk about here is that's the basilar post treatment, and then treating the left pica. What we did is we came from the contralateral side. So if you can see here, this is the stent coming across, and then you have the microcatheter coming in the other side. Ipsilateral, and so you have this sort of T configuration, which is a very stable way to treat it, and that's the final result. So we found that quite useful for these tough takeoffs. Sometimes it's hard to not go through the neck of the aneurysm from the ipsilateral side. There's different types of coils: framing coils, complex or 3D shapes, filling coils and finishing coils, different lengths, shapes, and what I call additions. You'll see them in the lab, have a play with them. The 3D is a new shape that's come out recently, which has been particularly helpful. You can see it's kind of like a box, so it's a little bit more box-like compared to the traditional complex shape, and this has been useful for wide-necked aneurysms. And then, of course, we frame with a large coil and then fill, and then you finish with the smaller short coils, helical coils, like this. The additions can be the PGLA or fibered coils. Fibered coils are particularly common in peripheral vascular. We don't use them so much intracranially unless we're taking down a vessel, but it provides a lot more thrombus formation. The detachment systems, again, play with some of them next door. There's electrolytic, the pressure-based ones where you basically click off the coil, and then there's the mechanical, the pressure one is the twist one from Codman, and then the mechanical, which just sort of pops off, which are pretty reliable. So my ethos for coiling is keep it simple. You don't have to find the most complicated way to coil an aneurysm. You should have a plan A, plan B, and a plan C. Have a game plan, whether that means the patient should be on antiplatelet agents pre-op or not. You need to think about that. What equipment you might need if it's a challenging arch, etc. What else you might need to have ready. Your working angles are the most important thing, so that's the 3D projections. And you need to know that the stent working projections might be different to the projections for coiling. So it's good to have both of those in mind before you start working. Where I trained at Jefferson, the kind of mantra was to get in and get out. Do what you need to do and get out. If you're in there for a long time, complications start to happen. So you want to be efficient. Doesn't mean rush, but you want to be efficient. And then finally, look for complications. They happen to everyone. The only surgeon that doesn't get a complication is the surgeon that doesn't operate. So simple coiling, I tend to do that subarachnoid hemorrhage if I can. Patients where you're not going to use dual antiplatelet therapy, obviously with a narrow neck. 3D coils have kind of changed our definition of what a narrow neck is. There's a lot of kind of broad-based aneurysms now with coiling that probably 3 or 4 years ago we might not have just because of the technology. These large aspect ratios or windsocks, like in this guy's head, you want to try and simple coil on those. Or if they have a shelf, sometimes an aneurysm will have a shelf which gives you enough of a neck to be able to treat with simple coiling. So again, looking for a narrow neck for simple coiling rather than a broad-based aneurysm, which is going to need an adjunct like a stent. So the narrow neck is ideal. That neck does kind of look like that light bulb. Of course, the light bulb has changed shape over the years, so we can't really use that expression. Young people might not know what that's about. Broad neck is not ideal for simple coiling. This is a rugby player from my native New Zealand who has a pretty broad neck. Again, not straightforward coiling unless you have adjuncts. So this is a case from last week. You can see in the middle plane there, we've got our roadmap just going up with our microcatheter into the dome of this ruptured PCOM aneurysm. This is a good example of a case that's suitable for simple coiling, just going past the aneurysm there and then letting the microcatheter lose its slack and then advancing into the dome of the aneurysm and then pushing in our microcatheter. You can see how the microcatheter, there's a lot of energy that you're pushing and not much is happening as the energy is dispended into the internal carotid artery there. So you have to be aware of that. It's a push-pull technique. So you're pushing the microcatheter as you pull the micro wire back, and always holding a little bit of forward pressure as you pull the micro wire back, because everything will tend to fall out as you remove that tension with the wire. And then just going in with this is a 3D coil, which is a very narrow-necked aneurysm. This is about as straightforward a case as you'll get, but pretty easy to get in there and pack that with coils. See if I can fast forward a little bit here. Okay, in the interest of time, I'm not going to show the entire coiling of that. Vessel takedown is a very effective technique. Hunterian ligation's been around a long time. Of course, this is John Hunter back in 1700s, knew the importance of vessel takedown as a technique. We typically have to do a balloon test occlusion to make sure if you take down that vessel, the patient's going to tolerate it. Patient's heparinized, we inflate a balloon, and then we look around, do an angiogram at the rest of the circulation and make sure that the vessel is going to be tolerated to be sacrificed. We do it with the patient awake, test neurological exam. We do it over about half an hour. Then we drop the blood pressure about 20%, and do the same thing, make sure the patient's still going to tolerate having that vessel occluded before you go on and take it down. There still is a stroke rate, even if patients tolerate a BTO, so you have to be aware of that. So this is a case, young lady in her 20s came in with this extremely large or giant vertebral basilar aneurysm. You can see the contrast there. That's just the filling portion of the aneurysm. In the AP, you can see this is a giant thrombosed aneurysm with the brainstem and the pushed right over to the right side there. There's just the 3D recon on the CT. When we did the angio, this is the left vert injection. Of course, all you're seeing there is the filling portion of this aneurysm. So there's a very large, partially thrombosed part anterior to that, which you can't appreciate on the angio. So we did a BTO. The ring is around the balloon and the left vertebral artery, and then we injected the right vert. And you can see there's a little bit of retrograde filling of that aneurysm, but it's significantly less. And there's some competing flow in the basilar right here from the collateral circulation from the anterior circulation. And this is going back, filling the aneurysm. And then similarly, you can see with the balloon up, you're getting retrograde flow down the basilar through the carotid. So we took that vessel down. There's these devices called a microvascular plug. I don't know if you guys have seen that, but that's a little plug that you can deploy. So we put some coils in and then deployed this plug and took down that vessel. and then that shows the collateral flow after that was done. Patient did well from that without any neurological deficit. You can see the brainstem has been completely pushed over, but that aneurysm is now starting to thrombose further, and we just brought it back for a 3-month follow-up angio. That's all the aneurysm that was left, and so we stent coiled that just to kind of take care of the residual, and that patient's intact. Dual microcatheter technique, the idea is using 2 coils to engage into each other to provide a stable matrix or coil detachment. Who has done a dual microcatheter technique? Anyone? Aaron? I learned from Aaron, so it's pretty uncommon, but it can be helpful. This is a patient with a pica aneurysm as well as a P1 aneurysm. They had bilateral internal carotid artery occlusions, and so their entire circulation was fed from the vertebral system. So this is a high-risk situation where you can see all those PO collaterals there. So we coiled off the P1 aneurysm, but I just wanted to focus on the technique here for the dual microcatheter technique. It's important when you're doing this to keep a sort of a mental note of which catheter has each coil or which catheter has each wire. Because it can be a little confusing when the 2 are overlapping and the detachment zones are sitting right beside each other, and then you have 2 coils going in at once. You'll see in a second. It can get a little confusing as to which coil is in which catheter and so forth. You obviously don't want to prematurely detach the coil. So the 2 microcatheters are advanced into the dome of the aneurysm there, and then we deploy them both kind of slowly at the same time to kind of intermingle those 2 coils to get a more firm substrate there so that it is more densely packed. So that's the wire coming out. So we've got both microcatheters in the dome of the aneurysm. And then we should have a couple of coils coming up here shortly. Okay, so the coils are going in, and sometimes you can use one shape of coil with one catheter and then a helical coil with the other. So in this case, I think we used a 3D coil with one and then a helical in the other, and that seemed to get a nice sort of combination of both kind of intermingling into each other. So you can see both going in at once, and just back to the previous point, it can be a little confusing as to which catheter is in which coil is in which catheter and the detachment zones. So you need to know which detachment zone on your microcatheter is associated with each catheter and coil. And so when we're done, this is the final result, which I think it's a pretty good outcome, not requiring a stent. Balloon-assisted coiling. Everyone's going to learn how to make this simple balloon model prior to using balloons in the lab. Cameron's a huge advocate and very experienced at balloon-assisted coiling, so we've been using that technique a lot with him. I'm sure Dr. Kalani's very familiar with balloon-assisted coiling, training with Cameron as well. It's really useful in subarachnoid hemorrhage, nodule antiplatelet therapy. There's different techniques. You can coil off, then deflate the balloon, or deflate after each coil. And I'd be interested, Aaron and Yasher, do you guys deflate after each coil, Cameron, as well? Or do you wait till everything's in and then deflate at once?
Confident enough that it's not going to displace when you let the balloon down. So it is a fair leap of faith to assume that first coil you place is going to be stable before you place the other ones. But it really does seem to work. I guess maybe kind of like the dual catheter thing, where you get enough coils in there together that they become more stable as you get more coils. And then frequently, once you have that dense frame, you just don't need the balloon anymore because the coils themselves protect.
Yeah, sure. how you do it as well.
Same. I mean, I train in Cameron, so I also of the same school.
Yeah. Aaron?
I would generally say yes, but it depends. If it's a ruptured aneurysm and I'm committed to coiling with a balloon, I don't want to use a stent, then I'll put in 3 or 4 coils with 1 inflation. If it's unruptured and I think that the first coil is okay, and then I put a second, maybe I'll deflate. But generally, several coils before deflating.
Yeah, I'm always a little nervous when you deflate the coil. So you've got to be familiar with the balloon in terms of compliance, its nominal diameter, as well as the deflation mechanism. Is it a dual lumen system like the Scepter system, or is it like a hyperform, which is over the wire? If you pull the wire out, the whole thing's going to deflate. And you've got to be aware of this sort of runaway balloon phenomenon, where you want to go to past where you want to go, then pull the slack out of the system, so that when you inflate the balloon, the catheter system is already tight. It's at full length. If you inflate the balloon after just going up, it's going to get all the blood behind it, and then it just goes flying into the middle cerebral or whatever. So this is a case we did a few weeks ago, and this is, you can see I'm testing the balloon in the Petrus ICA. So that's typically my practice. It's good to test it somewhere where you can't do any damage, and the Petrus is a great place to do that. So you inflate the balloon there. You want to confirm that you have contrast in the balloon. Obviously, if you don't know whether you've got contrast or saline, you should prep your own balloons, or watch the person prepping the balloon. Because if you don't do that, you could inflate it with saline or whatever, if it's been primed with saline, and that's going to be a fatal complication. So you can see here, now we're pulling the slack out of the balloon, and now I've gone up with the microcatheter. Microcatheter is in the dome of the aneurysm. This is a broad-based aneurysm in a young patient who didn't want a stent. She's looking at getting pregnant, so we didn't want to be on Plavix, etc. And you can see here now we're inflating the balloon slowly to create a neck across that aneurysm. And once we're inflated, and again you have to make sure all that slack's out of the balloon, so that it doesn't go flying down the internal. And so we continue to coil, and as Cameron said, once you got that first coil in, you're usually in pretty good shape. Didn't like the shape of that, so we'll go again. Get that first coil and get a decent sort of a matrix, and then we can continue coiling. But the balloon's inflated the whole time. Obviously, you need to make sure that your heparinization is adequate. In ruptured cases, patients can be pretty prothrombotic, so it's important to make sure you're checking ACTs constantly. So we've just done another map to get rid of our where our first coils are, and you can see more and more coils going in. Once the coils are in position, we tend to leave the leave the balloon inflated to remove the microcatheter. If there's any sort of straggling coil, or if it's stuck to the microcatheter, it's better to have that balloon kind of buttressing that whole system rather than pulling a coil loop with it. So that's what we're doing here, and we'll get that microcatheter out in just a second. Who here's done balloon-assisted coiling? Couple. And there we're just coming down with a balloon. And there you can see the contrast go out of the... See how it flew away there? So that's what can happen if you're not sort of holding on to it. And there's your kind of final result. Okay, stent-assisted coiling. Pretty much everyone here, I'm sure, has seen stent-assisted coiling. Have to be on dual antiplatelet therapy. You can jail the catheter or go through the stent tines. You've got to know what sort of stent you have, whether it's open cell, braided, what's the cell size, can you go back through it. Are you using one stent? Are you using two stents? That's sort of the primitive overlapping or flow diverting technique. Was using multiple overlapping stents. We still do that sometimes. And then, of course, Y stent or T stent for basilar tip. I tend to go for the jailing technique where the catheter is jailed behind the stent. It's a very stable system. Sometimes you're forced to kind of poke through the tines of the stent, and they coil through technique you can see in Figure B. But sometimes that can be tricky depending on the angles that you're trying to work through. It's important to know your types of stents. The Enterprise is a closed cell design there, so it tends to kink a little bit, and it's sort of harder to go through, whereas the Neuroform on corners will open up, and you can easily get through the stent tines. This is a braided stent. That's the Elvis stent. And then there's these newer technologies, the Pulse Rider there that you can see, which is kind of a stent kind of matrix that holds the coil ball up, but isn't kind of a true stent. Does anyone know what that is? That's a jailed Elvis. Sorry, I had to put that in. And so I'll just finish up with one last case. This is a giant basilar tip aneurysm, very tortuous anatomy. It was an extremely challenging case that Cameron and I did recently. Often it's very hard in these giant aneurysms to navigate the microcatheter and wire system because there's a lot of turbulent flow. The wire and catheter are really sort of flying around. So this is the so-called over the dome or round the world technique where we actually go up inside the dome of the aneurysm and then out the PCA in order to deploy that stent. And this is the kind of 30 or 2-minute video version. This case took us about 4 or 5 hours, but it took us about an hour and a half or 2 hours to do this part of the procedure. So this is it's a very kind of challenging aneurysm to get out that P1 and to kind of use that push-pull technique, pushing the microcatheter and wire to get that microcatheter out as far as you need to go. So we're able to get it out far enough, out that PCA, and then remove the wire. And you can just see that's the stent. It's a little hard to see, but you can see that's the stent coming out here. And we're deploying this is an Elvis stent. We're deploying that around the base of the basilar tip now in order to do a Y stent configuration. You can see there we just loaded the stent. So you can try that in the lab where you basically just you're pushing the stent. You've deployed about 70 or 80% of it. But then if you push it, then you get a little bit more of a shoulder that goes into the base of the aneurysm. Then following that, the plan was to place a second stent into the to the left PCA in order to get a kind of a Y stent configuration. The left PCA was significantly easier to get into, and you can see there we've got out our left PCA now, and then we're deploying a second Elvis stent, and this one's considerably more straightforward. So again, now we've protected our PCAs, and once we've done that, then we can get on and do the coiling part with the knowledge that our PCAs are protected by the stent, and as you can imagine, there's some pretty long coils had to go in to get this one finished. It's always difficult to get a complete occlusion of these very broad-based basilars just because of the nature of the outflow, and the inflow is very kind of bulbous. But I think in this case we got a nice result. So we'll skip through to the kind of final result here in just a second. So once we were done, that was the final. With good flow out the PCAs. So in conclusion, if you can, simple coiling is the best. The range of adjuncts that we have, that we've gone through, you've got to know your patient, know your equipment, what's your skill set, what have you done before, and also the team around you. And the place to practice is in the lab. So those are a few of the kind of techniques that we have